Good morning, everyone. My name is Robert Hersey. Happy Thursday to each of you. And on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Person-Centered Recovery Planning, Partnering in Process and Documentation. This webinar is being made available through a collaboration of the Florida Department of Children and Families and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them to all panelists by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the Communicate menu. One of these options is on the screen now, and all options are posted at the top of the chat panel as well. After ensuring that your volume, both on your computer and speakers, if applicable, is not lowered, you may click Communicate menu, then click the Audio Connection panel. Click Disconnect, follow the first two steps again, and click Call in using computer and follow the instructions. If you continue to experience poor audio through your computer, try using the I will call in option under the Communicate menu. The access code and event password are on your screen and in the chat panel. You must be connected to the audio of this presentation and view it on screen to receive a certificate of attendance. We are unable to verify your attendance if you are not connected to WebEx via your computer or mobile device. Therefore, audio-only attendees will not be eligible for a certificate of attendance or CEUs. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording and PowerPoint, visit www.fada.org, navigate to the Resource Center, and click on Training Library as shown on the screen. Today's webinar will feature a sample assessment called Roma's Story. To ensure all attendees are able to view the case study sufficiently, a PDF copy has been provided via a link found at the top of the chat panel. If you need access to this document at any time, please send a message to all panelists. The presenter will let you know when the case study is reviewed so you can refer to the document. At the end of today's presentation, all attendees will receive instructions on how to access an updated PDF of both the PowerPoint and assessment with additional information shared during the instruction. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct you to an evaluation form on the FADA website. You will first need to register or sign into your account to complete the evaluation. Please ensure that your name and your email address match your webinar attendance. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the entire webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at midnight on Tuesday, April 2nd, 2024. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license prefix and number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors the arrival and departure times of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. We encourage you to complete the survey as soon as possible. If you experience technical difficulties accessing the survey, please fill out a contact form at www.fada.org or email training@floridabha.org before the evaluation closes. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, the Florida Alcohol and Drug Abuse Association, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenter today is Janis Tondora. Janis is an associate professor in the Department of Psychiatry at the Yale School of Medicine. I will now turn it over to her so she can tell you a little bit more about herself.
Thank you, Robert, and good morning, everyone. It's good to be here with you all. I can give you a little bit more of a sense of my background and some of the experiences I hope to share with you today. So I am a clinical psychologist by training. I've been at the Yale Program for Recovery and Community Health over about 20 years now, and I am very passionate about the translation of recovery-oriented values and philosophy into recovery-oriented practices, especially as it relates to the practice of collaborative recovery planning, which is the primary topic that we're going to be diving into together today. And I've supported person-centered recovery planning in lots of ways throughout my career in terms of doing big research projects, developing different educational curricula and tools, and both teaching and learning from, I think, probably about 25, 30 states or so now that have been working hard at implementation. So that's a bit of the sense of the professional background that I bring to you all, but I also have a real personal passion for this topic. I am a loving mom of a young autistic adult who has struggled at times mightily with the mental health consequences of being neurodivergent in a very neurotypical world. And myself personally, I've navigated very serious medical issues over the last decade or so. So I spend a lot of time with doctors. So I've seen the healing power of person-centered planning, but I've also known the upset and the concern when my voice and choice feels like it may have been trumped within the process of collaborative planning. So again, this topic resonates with me on a number of levels, and I'm excited to be here today, share more about it with you all. I may be a familiar face to some of you because I actually did a similar webinar going back at least 5 or so years ago now. And I think there's a recognition in the field, especially with the last events of a few years, that there's been a lot of huge staff turnover in the field. And also with a topic like this, it's not always easy to go from a didactic seminar to implementation. So boosters and kind of refreshers are often very welcome. So for those of you that may have participated in that earlier webinar, absolutely welcome comments, observations into the chat box. As Robert mentioned, we're going to keep an eye on the chat, and in some cases we may stop and hit the pause button and take a question from the chat. I may also say that's a great question, but I'm going to get there in about 5 minutes in the, the slide sequence. So kind of hold that thought, and we will try to save at least a few minutes at the end for questions. And we have a pretty packed agenda. If we don't get to all of the questions, know that Robert is going to strategically be dropping into the chat a number of my different, favorite kind of tools and resources to support person-centered planning. So that's just a little bit kind of about the background. And I'm going to go ahead and dive in here a little bit about our learning objectives. Essentially, we want to walk away with a solid definition of what person-centered planning is. I want you to understand who's talking about it, and who says increasingly that it's required in terms of, federal requirements, program requirements, certainly understanding how this model of planning differs from traditional models of treatment planning that we see across behavioral health and social service systems. And of course, because we know it's a source of much frustration and confusion in the field, we want to make sure that you walk away with a better sense, essentially, of how do you write a plan that honors a person and a family, but it still satisfies your chart, right? Because we know that you all are subject to a really complex set of fiscal and regulatory oversight. And I wouldn't be here sharing with you all today if I didn't think it was possible to do both things in the context of one quality plan. So that's a little bit about what we're going to cover in the time we have together today, and a little bit about my background. But it's also helpful for me as a facilitator to know who's in the room with us today and what hats that you bring to today's conversation, because then I can kind of tailor my remarks a bit. So I'm going in the background to ask Robert. Looks like he's already done it. He's opened up a WebEx for us. This is set up as multiple choice, because we recognize that you may be wearing multiple hats in today's conversation. And I just want to make a quick note while you're responding, just of language choices today, especially as it relates to individuals and families who use services, right? There is no one agreed upon term in the field that feels right? This is really should be driven by what a person's preferences are. You might hear service user, client, person in recovery, survivor, person with a disability, lived experience, you name it. So really the golden rule here is when in doubt, ask. And I recognize that I'm not going to use everyone's preferred terms today. And I just wanted to kind of acknowledge that tension while you're completing our poll for us here. Robert, in WebEx, just help me. So I'm a Zoom or a Teams person, everyone. So WebEx is a little new to me. Do you share the results in WebEx? I see them, a small window in the chat, but are you able to share the results?
Yes, so it looks like we have about a little over 20% are direct support practitioners. We have a few individuals who are peer support and specialists or supervision and team leaders. We do have a couple people joining us who are family members and natural supports, a couple of guardians and conservators. We have about 20 people who are in leadership and administration. And then we have about 13 people who say they're advocates. And then 5 people say they're service recipients or person with lived experience.
All right, perfect. So we've got a very diverse audience today. That's great. Implementation of this kind of model in process and in documentation, it takes the engagement of stakeholders across all levels of the system wearing different kinds of hats. So I'm really glad that our group we've gathered today reflects that. All right, so here is our definition. Person-centered recovery planning is a collaborative process between the person and their behavioral health care providers and natural supporters that results in the development and implementation of an action plan to assist the person in achieving their unique personal goals along the journey of recovery, right?
Hey.
So we're gonna go ahead and unpack each of the components of this and talk throughout the time we have together about how this translates into practice. Eric, were you trying to jump in from a technical perspective? I saw you come off mute.
Sorry, no, I got a call and did not mean to unmute.
It's all right, no worries. All right, so what are some of the forces and influence pushing for the implementation of person-centered recovery planning? First I would say this is a values-driven approach. For many years, I referred to this kind of as the golden rule: treat people as if we would want to be treated, or how a loved one would want to be treated. But then couple of years ago, someone interjected with a refinement of that and told me about the platinum rule, which I like much better, which is that, we really can't assume that the person sitting across from us has the same preferences for how they want to be involved in care planning as we do. They may have very different preferences in terms of their level of involvement, what they focus on. Those differences can be driven by individual, cultural differences. So the platinum rule really tells us we have to be authentically curious about that and not just think about what might work well for us, but really what works well for the person that we're supporting. So very much a values-based approach, increasingly endorsed by state level health and social service organizations at the national level for many, many years now. Going back over 20 years ago to the Freedom Commission report that was put out regarding the status of behavioral health. Looking at different funding influences, you see national standards increasingly influencing funding models. So some of you direct support practitioners that we have with us today, some of you may be working in the context of HCBS programs, home and community-based services, which according to the 2014 rule of the Centers for Medicare and Medicaid Services, they really require that a person-centered plan organize those services that are delivered. And similarly, more recent emergence of the CCBHC model that some of you may work in, the Certified Community Behavioral Health Centers model. You're offering an enhanced set of different evidence-based services, but there is an expectation that that overall plan of care is organized by that kind of umbrella person-centered plan. We've got lots of data and research that shows we get better outcomes for people when we practice person-centered planning. And, perhaps most critically, this whole sort of shift and evolution has grown out of increasing demand, vocalization, advocacy from people with lived experience and families who are saying that they want to have more voice and choice in their plans. And this model offers you some strategies and tools for how we do that together. So that was just a little bit about all the reasons that are pushing for person-centered planning and advocating for its implementation. We also know this is a very complex practice to integrate with quality and integrity, and there are a lot of concerns and reservations that can get brought up in the field. And so I want to acknowledge those concerns, and I want to get a sense of what is on your mind today. And Robert is launching the poll again to get a sense of, even if this is something that you personally do not struggle with, if you're an administrator or a team leader or a supervisor, like what do you notice in your organization kind of most gets in the way of implementing this model? And again, your responses will help me to tailor some of the things that I focus on today. You have the options in the poll that Robert has posted, and then these next few slides just lay them out for you on the slides. While you're finishing that up, I'm going to let my dog out. All right, Robert, can you give me a sense? It looks like
Yes, so there are a good bit of people that did not get to respond in the time, but it looks like it's a pretty even mix of options from the people that did respond. A couple of people said that it devalues the role of clinical experience. About 5% said people receiving services are too impaired or uninterested. Another 5% said documentation puts us at risk for compliance issues. Looks like the most response came from letter D, sometimes managed care, sometimes managed care organizations, local management entities. 3% said letter E, the forms, templates, electronic health records don't have the right fields. Next highest was letter F, there is not enough time to do PCRP, the caseloads are too high. And then just a few people for letters G and H respectively. If PCRP increases choice, how do we manage risk issues? And don't we already do it? Is it really any different?
Okay. That's very helpful for me. So in some ways, these are the way that I come up with options for these polls is these are the most frequently cited concerns that I see around the country. So I think we've done a pretty good job in anticipation of that. And pretty much everything that you've all identified are things that I'm going to be addressing throughout the course up until noon here. So without further ado, let me continue on to some of the content, starting with this big picture view that is sometimes helpful for people around the model of person-centered recovery planning that we refer to as the 4 Ps, okay, right? At the bottom of the pyramid, we have to hold that philosophy of recovery in our hearts, right? That folks can and do recover. They can and should have maximum control over decisions that impact their lives, their experience and care. That type of philosophy should inform a little bit of a different type of process in terms of how we're sharing power and decision making, what planning meetings and conversations look like. Out of those meetings and conversations should come a plan, whether that's on paper or an electronic health record, that oftentimes looks very different from a traditional treatment or service plan. And then keeping in mind, lastly, that all of this is in the service of really a higher aspirational purpose around not just focusing more narrowly on the traditional targets in behavioral health systems around reduction of symptoms or substance use or staying out of the hospital, but really around helping people build that good life worth living. So this is a big picture perspective. I promise you we're going to spend the majority of our time on that golden part of the pyramid, because as we saw in your poll, and as I knew coming in, this is a source of much confusion and frustration. But given that it's really critical, some of the differences in the planning documentation are really rooted in the process, I want to say a little bit about that process and how it might look different. Before we go there, a couple of words around what person-centered recovery planning is not, because there's some myths and misperceptions out there in the field. So some of these already came up in the poll, right? That people really struggle around how do we weave that golden thread of medical necessity, and how do we do that in a way that we're not going to put ourselves at risk for compliance issues, right? Came up in our poll. I'm pretty confident that by the time we work through our Roma example today, you're all going to see how we can write a plan that honors a person, but yet it maintains the necessary rigor, clinical rigor in your documentation that's required of funders and regulatory bodies. It's also not a model that is reserved for people who are, quote, high functioning. I actually don't like those terms, high functioning or low functioning. They don't tell you a whole heck of a lot. But sometimes people will say, we can appreciate this model, but Janis, you don't really know how impaired the people are that we serve here, okay? So this makes sense with somebody who's, advanced in their recovery and well on the road in their recovery. But how does this work for someone who's maybe really early in the process or really struggling with, long-term persistent symptoms or issues with substance use? So what I will tell you, and again, this came up in your poll pretty high, is that it is a model that universally says that person-centered planning is a right of all people who receive services. Having said that, it recognizes that the practices and what it looks like in practice need to be flexed based on both the strengths and the struggles that a person's bringing to the table. okay? So you may have some people who enter into the process, they're already their own best advocate, they're able to articulate their goals, they're able to talk about, you know, what they think they need, and the kinds of things that they want to work on. You may be supporting someone else who doesn't even use verbal language to communicate, or maybe they're in an early stage of recovery and maybe they're mandated, you know, into care, and they don't have that internal motivation. And so I want to acknowledge that the actual practices look different, and I do know we need to adapt them, but fundamentally the model applies to all people. I would actually argue that sometimes people who have more significant impairments or struggles are most in need of this model to really, you know, again, kind of reclaim some of their independence around their desired goals, community inclusion, et cetera. Okay. It's not a model that is anti-clinical or anti-treatment in any way. This is very much a partnership-based model. We use the analogy a lot of trying to get people into the driver's seat. But that doesn't mean as professionals that you get kicked out of the car. Again, I think when we work with the Roma example, you'll see the really nice blend of voice there, okay? It's absolutely possible to do responsible risk assessment and do our due diligence around that in the person-centered recovery planning world. We may be challenged to maybe use some different kinds of tools when we do that, to more actively involve people in designing those risk and safety plans. And then lastly, this is not kind of an add-on or like a separate program. Sometimes, you know, people have initiative fatigue, but really person-centered recovery planning is kind of an integrating framework and quality of care. And it integrates everything from all of your cultural responsiveness and your DEI efforts to trauma-informed care, best practice motivational enhancement, all those kinds of things, okay? So I think, again, before we talk about what it is, I wanted to address what I see as some of the kind of confusion and misperception in the field, okay? One other thought could be the topic of its own webinar, and oftentimes is that today's webinar is really focused on tips, tools, and strategies for people who are working at the micro level, like direct support practitioners, agency administrators, folks who are involved in actual service, you know, delivery. But the truth is, this is more about, not only about individual competency among plan facilitators and plan writers. Even the most talented and person-centered of direct support practitioners is going to have a very hard time practicing this model if it's not embedded within a larger system of care that is also committed to person-centered approaches, okay? So this is a really critical point just to keep in mind, that you have to really embed the practice in that larger systems alignment. So everybody has a role to play. This involves, you know, mission and vision, policies and procedures, how we do quality monitoring and measurement over time, how we design electronic health records, how we engage people in recovery and people with lived experience. And an acknowledgement, of course, another important acknowledgement is that I think it's important to just recognize that this kind of work is very high stress, very high rates of burnout, especially over, you know, the last 3 years, the COVID pandemic, the behavioral health force kind of workforce crisis and shortage. So I come to this work always with the assumption that people are doing the best they can in the moment with the context that they're faced with, right? And that's true as it relates to person-centered recovery planning as well, okay? Having said that, we also need to be able to acknowledge that there's always improvements we can make and always things that we can do differently. So please don't take today as a big criticism or an indictment of the good work I know you're all doing. It's just an opportunity to learn and take it to the next level, okay? So I'm going to invite you to use the chat box now. So if you can please get ready to do that. First question I'm going to ask you is, think about how we traditionally define improvement in behavioral health treatment systems. Think about traditional treatment systems. What are the things we value as outcomes? What do we tend to focus on historically? I want you to go ahead and just put some, decrease in symptoms, behavior changes, better behavior, compliance. Yes, Dana, focus on compliance of all shapes and sizes, better outcomes, emotional regulation. Yeah, increased awareness, often referred to as insight, showing up at your appointments, functioning, increasing coping skills. How about the way that someone takes care of their personal appearance or their personal space at home in a household? There's a 3-letter acronym that we focus a lot historically. Anybody want to take a guess in the chat box? Yeah, ADL's good, Rebecca. Great. Good, a lot of focus on crisis management, increasing utilization. Okay, hit the pause button for a moment with your chat. Now I want to invite you to answer a very different question. And the question I want to invite you to answer is, take off your hat as a direct support practitioner, peer supporter, leader, administrator, whatever hat you were wearing today. I want you to now think about yourself just as a human being. And I want you in the chat box to try to spontaneously write down, what are the 3 things that are most important to you in your life personally as a human being? Like, what gives you a sense of identity, a sense of purpose? Why do you get out of bed in the morning? What brings you joy? And I just want you to put some of those things in the chat box. Love, family, my faith, church, connections with others, to be heard. We've got some furry friends showing up in the family category: life, love, and happiness, peace of mind. Oh, cats. We've got a little cat lovers in there as well as dog lovers. Great. Being a good grandma, being a good mom. More reference to spirituality, however a person experiences. Being happy at work, having a job I feel good about. Crafting. We may have some crafty folks out there, some musical folks out there. I love to dig in the dirt. I feel very grounded when I'm in the garden. Okay, excellent. So here's what I want to show you. You can feel free to keep putting stuff in the chat box. I want to illustrate something for you. When I asked you to think about, what do we traditionally value when we look at outcomes for people with behavioral health concerns and traditional treatment systems, we got a list that looked a lot like the list on the left, okay? But yet when I asked you to think about, what gives our own lives meaning personally, right? And what kinds of outcomes in our own lives do we value? We got a list that looked much more like the list on the right. So I want to invite some folks in the chat. What do you notice about these 2 lists? How are they the same, different? Anyone want to make some observations there? I'm going to give you a second to do that. So the left is kind of very clinical, narrowly. Yeah, good. Clinical is not a bad word in this model. I want to be clear about that. But it's kind of narrow management, almost exclusive focus on clinical stuff, whereas the right is much more kind of personal. The one on the left is about kind of the system and what it focuses on. On the right is what the person, what's important to them. Head versus heart. I like that, Michael. Yeah, needs versus wants. They're intertwined, but the right is a lot less psychobabble. You're right, even the language is different. So if you notice, like when some of you put love in the chat, right? And we think about love and intimacy in our own lives as human beings in terms of partnerships. But oftentimes when we talk about it for people who receive services, we say healthy relationship and boundaries, okay? Good. All right, very important observations. So here's a thought I want you to hold in your head for a minute, just for a minute. If you have 3 things in your head, or even 2, just imagine right now that I'm crossing the second thing off of your list. as a human being and saying that that thing can't be in your life, either long-term or maybe even just not right now, but I'm going to take that thing away. Okay. I just want you to think about emotionally in your gut what that would feel like if I crossed something off your list. Anybody want to put some responses about emotionally in your gut, what that would feel like in the chat box? Threatened, anger, nope, in capital letters, exclamation, painful, abandoned, heartbreak, feeling gutted, loneliness, anger, disappointed. Okay. Yeah, I've had it actually happen to me, and it's totally defeating. Right, exactly, lost. Okay. So I spend time on this as an opening exercise because I think it's very powerful, and in some ways, I think it can shortcut a lot of didactics around why this model is important. Because the fundamental take-home message of starting with this exercise is that despite the progress we have made in recent years in behavioral health systems transformation, treatment planning can still feel like a place every 3 months, every 6 months, where people go and someone else other than them has the power to say what 2 things end up on that plan and what 1 thing gets crossed off or has to wait. Okay. I'm not saying to all you direct support practitioners, none of us go into this business to cross anything off of anybody's list. Like I was saying before, this is a complex mix of systems pressures, and we got to figure out the medical necessity. But nonetheless, for whatever reasons, there are lots of folks that still feel like they don't have that kind of say or control in the process. Okay. So even just give you concrete examples, a person who says to you over and over and over again, I really want to get back to work and be a good provider for my family. But if that person is told, we know that's important to you, but you've got to do 90 meetings in 90 days, and we've got to have 90 days of clean tox screens. And once you've done that, we'll refer you to supported employment. That's crossing their deep desire around employment as a valued goal and source of identity off of their plan and deferring it. Okay. Or people who may live in congregate residential settings like group homes. Before I die, I just want a key to my own apartment. I want my own place. And I still, much better than years ago, but I still sometimes sit in team meetings where, again, we know this is important to you. We will get there, but the team's really not comfortable supporting that decision until we have about 6 months of medication compliance. Okay. So I want you all to sort of sit with those examples, sit with kind of thinking in your own mind what it would be like to have something on your list, either deferred or crossed off, because that's what really sort of provides the sense of urgency around how we can do better together with this model. Okay. So let me give you a quick illustration before we dive into all these key practices and practice with the Roma documentation. So this was a story of someone that I'll call Mr. Gonzalez. He was a young married Puerto Rican man. He had a couple of little boys. He was struggling with his use of alcohol, which he would often use to manage very distressing symptoms of bipolar disorder or mania. And when he was particularly symptomatic at one point, he was increasingly having some of these, large blowouts at home with his wife. And at one point in the presence of the young boys, his sons, things got really heated. He laid hands on his wife, and she was shoved to the floor. She did not get seriously hurt, but that incident in the home prompted a couple things. It prompted an on-site emergency evaluation and a domestic disturbance call to the police, and subsequently a brief inpatient hospitalization, with the last consequence being that Mrs. Gonzalez said very clearly, you're not going to see me or the boys until you get it together. Okay. She was actively involved and willing to be involved in his care as he transitioned back to outpatient, but was also setting some really clear limits in the expectations. And this was devastating to Mr. Gonzalez, because he would tell you that his love for his family and his faith in God, he was practicing Catholic, really kind of kept him going in difficult times. So when I was approached by the clinical services agency about this story. They were saying, we think this gentleman has a ton of potential, but he's really angry. He doesn't want to meet with anybody on the team. We're having a really hard time engaging him. And so I said, okay, send me a copy of the working recovery plan that you developed with Mr. Gonzalez. And this is basically what they sent me, like a very kind of cookie cutter, pathology focused, compliance focused plan that really made very little space for the goals in his life that were most important and motivating to him. So he was kind of feeling like this, I'm here to give you back your goals because you all left them on my recovery plan, because these are not his goals in life, right? You know, who knows what's his goal in life? What's his most deeply valued recovery goal? You know enough about his story. What do you think it would be on the recovery plan? Who wants to throw it into the chat? Yeah, he wants his family back. He wants his family back, okay? Be with his wife and kids. Be a good role model for his boys, okay? So this model is about kind of figuring out how do we address some of these really significant concerns that come up around his experience of mental health distress and substance use, but at the same time, making sure the plan stays true to what's most important to him, okay? So how do we need to be able to practice? What kinds of skills and abilities do we have to have in order to be able to collaborate with folks in this way on the co-creation of the plan? This is just a really nice resource. I'm not going to get into it in detail other than to tell you it's a great resource. There's a live link there for you. It was produced by an organization called the National Center for Advancing Person-Centered Practices and Systems. That is a federally funded by CMS and the Administration for Community Living, and it's a cross-disability initiative that is really trying to advance person-centered planning implementation across the country. And I've had the pleasure to do a lot of work with them over the last several years, especially as it relates to the translation in the behavioral health space. So please do check out, there's a kind of 5 core competency domains with lots of tips and tools for how we can, again, get ideas and strategies for feeling more comfortable and confident in each of these areas. So these are key process reminders about, again, in that pyramid, the kinds of things that need to happen as you get ready to document the plan. So, you know, we want folks to feel like they're a partner in planning meetings. That could be as simple as giving them advance notice that it's happening. Listen, it's that time of year, treatment plan coming due. What do you think is most important to you that you want to work on? Is there anybody that you want to involve? Reasonable control over the logistics. When might that meeting happen? I'm not suggesting that someone can call you up and say, well, I want my mom to come with me, so it can only be the second Tuesday of the month at 1 o'clock. But I am talking about reasonable control. So for example, when I go to the doctor, I am, you know, frequently will say to them, listen, I'll come in any day of the week, but if you can make it for 3 p.m. or later, my husband can come with me. And he's a really important part of my medical decision-making, right? So I think we have to challenge ourselves. Do we do the same, you know, in the context of the behavioral health space? Certainly better, but not always, okay? We want folks to get a copy of the recovery plan that fits with transparency. It's really important in terms of the plan being a manifestation of the partnership, okay? And it should stay true to the dialogue in the meetings. And even the structure of your meetings might look a little bit different. You know, thinking in terms of how you share power and making sure you redirect the conversation back to the person, and even educating the person ahead of time about what the planning meeting or conversation is all about so that they can feel more comfortable as an active participant. You're hopefully going to see more natural supporters, friends, families who get involved in all of that. They have important contributions to make to this process, along with all of the professionals. And we want to be including traditional and even non-traditional professionals. So I was really excited to see we had some peer specialists with us here on the line today. And I will tell you that in all the states that I have done this work around the country, the ones that get the most traction in implementing person-centered planning are the ones who are able to figure out how to appropriately use the lived experience expertise of their peer support workforce, okay? I mean, peer support is uniquely positioned to help folks have more voice and choice and to kind of get beside them and promote that. So be thinking about the role of your peers. Really should be a lot of focus on connecting people to naturally occurring recovery promoting activities in the community. You know, many of you in your chat box exercise said that spirituality was a huge part of your recovery, as it is for many of the people that we serve, right? So instead of starting another spirituality group at the psychosocial rehab center, we need to first really be thinking about, can we help a person feel well enough that they can get back to Sunday services down on Main Street at the parish of their choice, right? Strengths-based approach, both in the plan focus, but also in the language. We'll take a little look at that in a minute. And all of the above, of course, is impacted by cultural factors. I wish I could speak longer about this, but I'm conscious of wanting to make sure I give you lots of good tips about the documentation. But what I just will remind you is that, you know, person-centered planning, self-determination, independent decision-making, individuation, those are, you know, overall very Western white concepts that are valued, okay? Of course, certainly across cultures and within cultures, you have individual variation, but it is true that there are some people, based on individual or cultural preference, they want more of a collective decision-making process, or they want to perhaps defer to a really trusted provider, okay? So these are not kind of universals. This goes back to being authentically curious and that platinum rule and figuring out what works for the person around the table, okay? Another resource in here about just acknowledging unique challenges of creating person-centered plans in the context of family-centered service, right? Because sometimes the goal of the youth doesn't always align with the goal of the parents. I just survived the teen years myself, and I know this to be true. So it takes a unique set of skills. And there are some tensions both in the process and in the documentation that come up when you're doing family-based work. And I just wanted to point you in the direction of a great resource that came out of the National Quality Foundation. There's a live link in there that really could give you, again, some nice resources to help navigate some of those tensions. Okay, that was a mouthful, but without further ado, I want to leave you with this section of the didactic remarks. Since I went through that so quickly, this is a tip sheet on how do you recognize good person-centered recovery planning process, okay? Robert actually has a link to this document he can drop into the chat box for me. And whether you're doing one-on-one planning meetings prior to the development of the plan, or whether you're doing kind of team-based planning activities, there are lots of different reminders in here for you about the kinds of things that we might be looking for, and just kind of some of those reminders that I just covered pretty quickly, okay? So we're going to dive into documentation in the whole balance of the time we have. And before we do that, I'd like to share a little video with you. And it's going to illustrate the powerful difference, how people feel the difference in systems of care that are working really hard on implementation. So I'm just going to invite you to watch this quick couple-minute video.
Treatment planning way back was not much of a treatment planning. It was more of me coming to the mental health center and expecting them to be able to fix me.
The treatment plan was essentially a number of prescribed treatments for problems.
I really just wanted to be heard, and I wasn't. I didn't feel that I was totally heard. And I thought that we were just going to be, I was going to be a zombie for the rest of my life, you know.
Well, early on, when I first was hospitalized, back then it was just maintaining you, keeping you quiet, and that was it. I mean, there's no idea of recovery or any suggestion that things could be different.
I seen that they didn't have no hope for me, so why would I have any hope for myself?
I always had the feeling that the clinicians or the providers or whatever, they were all the way up here, and I was way down here. So I still had that like less than thing going on, and it was very hard for me to trust.
We began this process of trying to turn the paradigm around and create something that was different.
Person-centered planning is about connectedness, you know, feeling connected to something, feeling a part of something.
I'm on the team. My treatment has changed since person-centered because now I am a part of the team, and so I'm involved with the planning of the dates. I'm given a copy of it, so I feel like we're more of a team working towards my goals. Yeah.
Treatment planning involves the client a lot more. We actually have them sitting in the room with us to talk about their recovery and what they want and what their strengths are, and they get to have a say about who they want to be a part of their recovery. We also try and get families to be more involved than before and have the families also sit in on that treatment planning session. And it's more of a dialogue between the treater and the consumer.
They just make me feel supported. And I know that I can do anything, that they want me to do anything that I want to do for myself in my life.
I was able to get a copy of my treatment plan. I was able to remain focused on something, on a goal. I was able to set goals. I was able to go to new heights that I thought I'd never be able to accomplish before.
Terrific. I have control of the slides back. I see some good comments coming into chat. That's one of my favorite quotes too, Christina, where Kim just says, I'm really a part of the team. Like, I feel like a part of the team in this process. So I can't say it any better than that. And just, I know this is a very complex practice. There are challenges in implementing it. I'm going to try to help you with this particular challenge as we move forward, but I thought I'd share that quick video just to remind us that the effort in the long run is ultimately worth it, because it really does impact people's experiences. Okay. So many of you pointed this out in our earlier poll and feel caught between a rock and a hard place, right? On the one hand, you have folks like me talking about being collaborative and person-centered and strengths-based and all that kind of stuff. But then on the left-hand side, you have lots of folks poking around in your charts and your health records with red pens, talking about compliance and regulations and required paperwork. And it can be really hard to figure out, how do we reconcile these things and help them live in the context of one good quality plan, and do that without creating plans that are so detailed that no one's going to use them, right? So I often still sometimes see plans that have 5 or 6 goals. Each goal has an objective, then a set of interventions. And then ultimately, that's not only an incredibly challenging plan for you to write and stay on top of, more importantly, the change process doesn't really work that way for human beings. I mean, I don't know about you, but I'm not working on 6 active goals in my life right now. So there's a way to do this to really kind of integrate it, to make it both more person-centered and efficient, okay? So hold your hats. We're going to use the time that we have here. I've already previewed a little bit of with Mr. Gonzalez that we're going for a different kind of a model here. Now we want to illustrate it. What I'm going to do is I'm going to coach a little bit to each of these plan documentation components and give you some tips. And then we're going to pause, and around each of those orange boxes, I'm going to invite you to think about, in accordance with the quality criteria, what might be a good goal for our Roma story, our hypothetical Roma, okay? So when we get to that point, Robert's going to drop it in the chat. You could even drop it in the chat now, just to make sure if any folks have technical difficulties, they've got it when we get there, okay? So from an overarching structure perspective, I want to point out how a good person-centered plan is very different structurally from a traditional problem-centered plan. So you see on the left, we tend to organize traditional plans around the problem statement. And then each problem has its own kind of short-term objective, right? So I've got medical issues, I got to comply with my medical care. I've got anger management issues, I'm going to reduce my outbursts. I'm not taking care of my hygiene. The objectives around, showering or bathing regularly, okay? Again, organized around the problem list that comes out of the assessment. This model challenges us to take a step back, and before we start talking about what a person needs, finding out what they really want in their life and what's important to them, right? And in this case, it may be I want to get my job back so I can be a good provider for my kids, okay? That doesn't mean that we neglect the problems that popped up in the assessment, but we don't think about them in a vacuum from the person's life and goals. So if I'm having medical consequences of my health issues, I can't do too much physical stuff as I am working on my, employment search. Maybe I lost control at work, because I've got trauma issues and I had some conflicts and I got let go. Or maybe I really am severely depressed, and maybe one of the things that I neglect is my self-care, when I'm not feeling well, and I got to put my best foot forward for a job interview. Okay. And last but not least, maybe I was using substances at my last place of work and I called out too many times and I was absent, so I got let go. So I'm hoping what you can see is that already out of the gate here, there's a way to integrate and respect and target behavioral health issues that pop up in your assessment, but to not do it in a vacuum, in a way that takes us away from the goal that is most important to the person. Okay. So I am going to hit the pause button, ask Robert, it's already in the chat, the link to the Roma story. And I'm going to give you a couple of minutes to read the Roma story, because we're going to use that to illustrate and do some exercises moving forward here. So go ahead and access that. You don't have to read this tiny font on the screen. Please take this document from the chat box link. It's pretty dense, so I'm going to give it just a little more time. Tanya is having technical difficulties. I'm going to give the sort of quick highlights of the Roma story on the next slide. So hopefully that will be enough to help you out as we go through the exercises. I'm not sure what the technical issue is there with you for the link. You're getting a tip there in the chat. All right. So you may be finishing up. Just in the interest of time, I do want to offer a sort of a high-level recap. So Roma is a young 29-year-old loving mom of 2 teenagers. She is a survivor of multiple adverse childhood experiences, including loss of her mother, sexual abuse at the hands of her biological father. Many of these issues contributed to a long history of difficulties struggling with different substance use, major depression, PTSD, has struggled and interfaced with the criminal justice system, has developed medical issues along the way. But team is currently saying that, Roma is refusing to go see her doctor. She has hepatitis C. She had recently been incarcerated, released about 6 months ago. She does have a very supportive cousin who has temporary custody of the kids. But she recently started having kind of big arguments and blowouts with the teenage daughter who is 14 years old. And there's been some questions around Roma's use of alcohol. And when she was struggling with those issues, the cousin asked her to leave because when Roma left incarceration, she went to stay with her cousin for a bit. Cousin asked her to leave. She was referred to a local transitional shelter. There is DCF, Protective Services involvement, and an expectation that she engage in behavioral health services. She's doing very well at the transitional shelter. She's actually volunteering, helping out with some clerical and admin tasks. She is open to services, highly motivated to get her kids back, recognizes the need to get some things on track, and has many, many strengths, including the supportive cousin, creativity, kind of work history. And just a technical piece, folks are asking for sort of bigger font in the Roma story. You're not intended to read this slide back here. We know that's way too tiny. We got to try to get it to you through the link in the chat box. You'll get a full-size version to download, have it as big as you want on your computers. So just keep an eye out for technical assistance in the chat, okay? Same thing with this one. You don't need to read the tiny font. You actually don't even need a copy of this one. But before we build what a better plan, a more person-centered plan could look like for Roma, sometimes I think it's really helpful to start with what a traditional plan might look like for Roma and what we want to move away from. So it would be very easy to default to this style of treatment plan documentation. Problem number one, chronic psychiatric issues. What's your objective? Be med compliant, have increased insight, into your issues, have better anger management. Problem number two, long history of addiction, polysubstance abuse, etc. What are your short-term goals and objectives around that? Abstinence, submitting to toxicology screens, complying with all medical appointments. So you can see how quickly a plan can become problem focused and divorced from what is most important to Roma, okay? So we're going to talk about what it would look like to build a plan around what's most important to Roma, while also not neglecting the fact that she has significant mental health and substance use concerns, very much trauma related, that might prevent her from reaching her goals, okay? So the quality of the plan starts with the quality of the assessment. And we have to be thinking about expanding the territory that we cover. Typically, the relative ratio of focusing on strengths and interests, cultural preferences, stage of change, typically those things are getting very little airtime in the assessment. And we've got to put some more time there to really be able to flesh out and create a good quality recovery plan, as you're going to see in the Roma illustration, okay? And a good quality person-centered assessment should also conclude with some kind of integrated person-centered assessment, biopsychosocial summary, formulation, where you're not just repeating the facts, right? The facts are just like the what. You're digging a little bit deeper and you're kind of looking across all the assessment data and you're trying to get a better sense of why, what is going on here? What are we missing? What might be the most important piece of the puzzle to offer supports to Roma? This is just your best guess in the moment based on the data you have available. These stories unfold over time. You may sort of update what your hypothesis is about that. But it's a really important step in moving from the assessment to the plan to do this deeper level of person-centered thinking and conceptualization. So I want to just kind of give you an example. A lot of times I'll review an assessment and somebody has told me 37 times that Janis is med non-compliant and keeps landing back in the hospital. Then I get to the end of the assessment before the plan, and there's a paragraph. And what does the paragraph say? Janis has a long history of medication non-compliance. But you've already told me that 37 times in the assessment. It doesn't give me any more meat or sense of the story to write a better recovery plan. So we have to ask the why question. So I just want to illustrate this for you, because the answer to the why question, when you write a good person-centered summary, takes the plan in very different directions. So if a person is concerned about side effects, if they're in an intimate relationship and they're having sexual dysfunction, then maybe we need to bring a partner in or help them be negotiating with a doctor different types of medications. If a person has culturally informed natural alternative healing strategies, are we collaborating with different faith-based cultural healers, integrating alternative strategies? Maybe they're like my mom and dad used to be, and they take a ton of different meds. You know, my dad was up to, I think, 15 medications a day when we lost him. And it wasn't that he didn't think they were useful, but he could not track the level of complexity of what he was taking when. So that really speaks to the need for a more rehabilitative strategy where you're helping people practice and learn the skill of identifying pills by shape and color and packing a pill box, okay? So the answer to the why question is very important. And so what you're seeing on the screen up here is just one example of what an integrated person-centered summary would look like, okay, for Roma. The piece I have highlighted in red is really important because in the data of Roma's story, you know, Roma could very easily be described, we could default to a very problem-focused conceptualization and simply just say, Roma has anger management issues. She's had physical altercations with her daughter. She's minimizing her medical issues. She's not going to the doctor. She's refusing to participate in services. It could be very easy to do that if we don't dig deeper. But if you noticed something in the history and the sequence of that story, this conflict with the daughter is relatively new. And if you do the math, the daughter is now at the same age that Roma was when she became pregnant with a daughter as a result of the abuse from her biological father. So the daughter is as much as she loves her, she's a living, breathing, walking manifestation of the most significant betrayal and trauma in Roma's life, okay? So all the anger management and parenting classes in the world, not that they can't be helpful, but they're not enough. She needs really good trauma-informed clinical care, okay? Same thing is true. She's not just refusing to go to the hepatologist. She's terrified to be behind closed doors with a male authority figure for good reason. So then we have to get creative and start thinking about maybe you help Roma negotiate in advance. I know when I go to my OBGYN nowadays, like I don't have an exam with my male OBGYN provider. There's always a third-party nurse in the room, okay? I think just out of a recognition that it makes people feel more comfortable in the space. Could you help Roma negotiate something like that, okay? Maybe a cousin or a peer specialist on the team might accompany her, you know, to an appointment to see the hepatologist. So just really wanted to illustrate the critical nature of understanding the story and appreciating the strengths before you dive in to the development of the core elements, okay? So let me do that so we can get to the polls in each of these core elements. Let me also tell you, there's a lot of meat in these slides for a few-hour webinar. I want you to have them. I may not pause and talk at length about all of them, but I wanted you to have kind of a comprehensive set of tips and tools, but I promise I'll hit the highlights on each of them, okay? All right. So, big picture perspective, the long-term goal statement on the recovery plan. What do people want? They want all the things that are up on the screen here. They want the same things that you all wanted when you put your list of 3 into the chat box this morning in that exercise, right? They want to see their grandkids. They want to go to church and experience their spirituality. They want to finish school, have a place of their own. They want to be a part of the life of the community, okay? So from a technical perspective, in terms of how you document the goal statement, what makes for a good goal on a recovery plan, okay? So just remember, you want them to focus really on those things that are important to people, just like what you put in the chat box for yourself, okay? We want to move beyond just the narrow focus in the goal on the mental health or the substance use concerns. There's going to be other places in the plan where we really are able to directly target that stuff. Ideally, you want that goal statement to be a quote in the person's own words. They should be culturally appropriate to the person and the family. We've done a lot of our work with Latino populations, and you know, if you have a sick grandmother at home and you're graduating from high school, you may not be as keen as individuating and going off to college or trade school or whatever it might be, like other 18-year-olds, right? There might be a preference to really sort of stay home for a bit, be part of the family unit, particularly when you have an elderly person in your family who's ill. So just kind of trying to give you reminders that we have to be taking that into consideration across all aspects of the plan, okay? This screen in particular is important. You know, before I told you again, what are the kinds of goals we're moving toward? These are the kinds of goals that we're trying to move away from. If I review 300 plans, you know, a year across different states, you know, the 2 most common goals that you tend to see are achieving some kind of clinical stability or abstinence and medication compliance, okay? We'll talk about where and how to integrate the focus on the clinical issues, but nobody's long-term goal in life is to be compliant with services, okay? It's in the service of something larger, So on the left, what you have are just some examples of traditionally worded treatment plan goals versus on the right, what might be more person-centered ways of framing what is important to the people that we're serving and families, right? Like a person is not going to say to you, you know, I want to have improved boundaries and healthy socialization. They may tell you, like, I want to have friends and family in my life, or I want the other kids to like me, so I get invited to birthday parties at school, or whatever it might be, okay? So I'm going to look. You are welcome, remember, as we go, to put questions in the chat, and I will try to keep an eye on that. If you need to put any questions in the chat right now about the goal statements, please do that. But I'm going to ask Robert to open our first poll. You're going to choose what you think would be the best goal statement for Roma's plan, and then we're going to discuss a little bit, process that out.
Okay, everyone, looks like the poll is now closed. It does appear that the presenter is having technical difficulties at the moment. So hang tight for us just a second. We're gonna take, let's just take 2 or 3 minutes, give her time to get reconnected. So if you need to grab some water or use the restroom, be back, let's say at 11:18. We'll give it a couple of minutes for her to come back on.
I'm back.
Oh, there you are. Okay. Perfect timing. I was just telling everybody they could take a quick break, but what I'll do is I'll share the poll results, and then if you need to step away for a second, you can. But we'll keep going out of sake
No,
of
no,
time.
I'm glad to be back. I have no idea what happened, and then I was having difficulty spinning out, logging back in. But good thing it happened when y'all were doing a poll.
Yeah, so no worries. It looks like the majority of people that responded picked letter C for this one. A good 43% of respondents said letter C. I want to be a better mother for my kids and work on getting them
Terrific.
back.
Yep.
Just a handful of people spread across answered the other 4 options, but the vast majority picked letter C.
All right. So let me do this. Let me for those of you that chose something other than the golden one, C, which I would say is in fact the best of the options because it meets that different quality criteria that we were talking about. But let's talk a little bit about why maybe some of the others are not the best. Okay. So I don't want to lose control anymore. While you could hear Roma saying that, ideally, when you're creating person-centered plans, you want the goal statement to be something that a positive, that a person is moving toward in their recovery, as opposed to something negative that they're trying to stop doing. Okay. So we want to kind of flip that. If you weren't losing control, how would that benefit your life? Well, I'd be a better mom and be able to maybe get my kids back. Okay. Managing distress without drinking, potentially a very important part of the plan. But again, we want to try to focus the goal statement, the long-term goal, on that aspect, really overall quality of life of what's important to Roma in the roles that she holds in her life, especially as a mom. Okay, we're going to talk about how you address the trauma, the substance use, medical issues when we talk about the short-term objectives in a minute. Okay. The bottom 2, attending anger management, attending appointments by protective services. Again, those could be important parts of Roma's plan, but those are not goals, right? Those are not goals. Attending those things, those are services, supports, or interventions, whatever you call them. So again, we kind of hold that thought and we'll talk about where we integrate those later. Robert, I saw a quick note pop up in chat that someone said they weren't able to see the slides anymore. I don't know if that is a broader problem, but just wanted to make sure you saw that.
I did, thank you.
Okay. I need slide control to advance the slides, Robert. I think you have to give it back to me. There we go. Got it. Okay. Lots of different tips in here about how you might incorporate different strengths. These slides give you examples of what those might be. It could be personal attributes, previous accomplishments, compliments that you've gotten from friends and family members over the years. Lots of different ways to uncover these things. They can also be connections to other human beings or community-based resources. And when in doubt, what I would say, cast your net broad with the strengths because you'll never quite know how you're going to use them in the recovery plan. So I've even seen, I mean, even in my own health recovery plan over the years, I tried to get in shape for years and years and years with my health issues. And I was a little bit of a couch potato, but I always wanted a dog. And when I got that dog, you bet I was out there, you know, multiple times a day walking that dog, and that got me on the trail of sort of overall having fitness being a, you know, an important part of my wellness overall. So lots of different ways we need to be thinking about incorporating strengths, including incorporating them into the language that we use. So I'm just going to invite you, I want you to read the top paragraph, then the bottom paragraph. And I want to invite some comments into the chat box about what you notice that's different in the language that's being used. So go ahead and do that. Even just using her first name, Sandra, Brittany's pointing out in the bottom one there, it just humanizes the narrative right away. Maybe Sandra's preference would be to be called Mrs. Smith, right? But depending on, again, the name, the preferred name makes a difference. Yeah, first name or preferred name. Yeah, the second one, first one feels very accusatory. The second one is much more strengths-based, people are saying. Yeah, Sandra has worked with her doctor in the second one. So we give Sandra some credit for the hard work that Sandra has done in the recovery process, whereas in the first one, it basically just said she finally started being compliant and magically got better, right? Even like language in the first one, you know, about failed to report versus has been missed at recent, you know, clinics. These are really great examples coming in. Okay. So again, just be keeping in mind, really, I encourage you to check out your colleagues' feedback in the chat. There's some really nice observations here that especially remember, we are supposed to be sharing routinely copies of service plans with people that we co-create together. So it's more important than ever before that we're really being cognizant of using respectful strengths-based language and not jumping to assumptions. There's a lot of jumping to assumptions in that top one, okay? When you identify strengths, I made this point when I talked about how I finally got myself in shape when I got my puppy. The important thing is strengths are not just meant to fill in the box in the assessment or your electronic health record. We want to use them and capitalize on them in the recovery plan itself. They can show up in lots of different places, from goals to objectives to interventions. And I just offer you a couple of examples up here. All right. As much as we are focusing on strengths and interests and gifts and trying to capitalize on those in the recovery plan, that does not mean that we are neglecting the barriers, the clinical needs, the functional impairments that are getting in the way of what's most important to folks and perhaps preventing them from reaching those recovery goals, okay? So this is where we talk about the documentation of the barriers. This is an important part of how we're documenting these in the context of the assessment and plan is important for a couple of reasons. It helps us tailor our services and interventions, but also this is an important place to weave that golden thread of medical necessity for those of you that were bringing up the tensions around compliance and clinical rigor. So you got to ask yourself the question, why can't Roma just go out and achieve her goals tomorrow? And why can't Roma do it on their own? Okay, what's getting in the way of Roma's most important goal? Okay, this slide is not specific to Roma, but just trying to give you examples. You want to be descriptive when you describe these. I would say on the left-hand side, these generic terms around person has anger issues, depressive symptoms, addiction or substance use, you know, traditionally being documented in plans. Again, it doesn't give you a lot of detail about what that looks like in a human being's life. So maybe a person is having outbursts and conflicts with neighbors, or maybe they're so depressed they haven't been taking care of basic sort of sanitation around their apartment, and they have a housing voucher and they have a housing inspection and they're at risk of losing it. Or maybe they're struggling with substance use and the kind of crowd that they're with, and maybe that's led to, you know, police calls and lack of attention from the landlord about potentially being evicted, okay? So this gives you a more clear picture of how the issue is impacting a person's life. And also, if you notice a theme on the right-hand side, if we're more descriptive in our barriers, it connects the dots back to the goal statement and can be an important source of motivation and engagement when we're working with people, meaning that you're not talking with people about their anger and their depression and substance use kind of in a vacuum, but like, I'm bringing this up because what you're telling me, the most important thing to you in your life in recovery is that you want to hang on to your own apartment, okay? And when we're describing the barriers the way we are on the right-hand side, that connection is much more obvious to folks, okay? And can help, you know, again, with engagement, okay? So you have a sense of the long-term goal and what's important, strengths to draw upon, as well as barriers or needs that are getting in the way. Now we have to transition to the short-term objective. Some of you may refer to it as the short-term goal. We're going to spend a little more time here before we do our poll, because these are typically the source of the most confusion in treatment plan documentation. So the way that I want you to think about the transition is you've done your comprehensive assessment. You have a sense of the range of barriers that might be interfering with a person's recovery goals. And I want you to think about like plucking a barrier out of that list and then, you know, talking to a person and saying like, how could this thing change in a concrete way in a short amount of time, 1 month, a couple months? Like, how do we think this thing could improve in a way that you're going to feel like you're taking steps in the right direction? That's the transition to the short-term objective. Conceptually and from a definition perspective, what is the short-term objective? Short-term objectives are really, they're concrete, positive changes in functioning, changes in behavior, changes in status that feel meaningful to a person, that again, that they're moving in the right direction. They take the long-term goal, which could be years in the making and might feel overwhelming, and it breaks it down into manageable bite-sized chunks, okay? And bite-sized chunks that we think can be different for the better in a pretty short amount of time. So in that sense, they give people a sense of hopefulness about, you know, again, going in the right direction. So I'm someone, for example, I'm obsessed with my to-do lists and I write everything down. But part of the reason I write everything down is that when I have a lot going on in my life, or I'm going after like a big long-term goal, it can be really overwhelming. But if I'm like just systematically, okay, I got this thing done, let's take it off the list, okay? Pat myself on the back, take a deep breath, celebrate that accomplishment. Now I've got some energy to go to the next, okay? So they're really important conceptually in the plan. Technically, they're very tricky to write because they should be meeting this SMART criteria. So SMART criteria really should be applied at the level of the short-term goal or objective, okay? Remember, at the level of the long-term goal, we want those to be more organic quotes and statements, I statements that just come from the person or the family, okay? It's when we get down to this second level short-term objective that we want to be thinking about this technical criteria. So there's a little bit of variation in the field for what some of these letters stand for, but you can see it up there on the screen: simple or specific, measurable, achievable. Some folks might say the R stands for realistic. I'll talk about that in a second. And then time frames, okay? This mnemonic strategy may be helpful for some of you. If it's not, I always come back to the rule, like, read the short-term objective out loud to yourself and then say, are you going to be able to know definitively at the end of the time frame, did the person achieve it or not, without a difference of opinion? And if there's a lot of difference of opinion on that, then that means it was probably a little too soft or mushy on the front end. So I'll give you examples of how to tighten them up. In terms of the R, the relevant, a number of models will say that that's realistic, but you know, in all the work that I've done in different states, I've never really gotten a good answer to how realistic is different from achievable. There's a lot of overlap there in those constructs. So increasingly, I like to think about relevance, okay? Before you put a short-term objective into a plan with someone, you want to make sure it's relevant to them and it's actually getting in the way of what they're working on in their goal statement. So as an example, you may do an assessment and someone in the activities of daily living area, they may be struggling with their personal self-care or appearance based on, mental health or substance use distress. So if they're struggling with self-care or hygiene and their goal is to get a job in customer service, arguably, that's a very relevant thing to target in a short-term objective, right? You're going to be working with the public, you want to put your best foot forward. But then I often say, take a different person and their goal, they're a grandmother and they're staying home right now, helping out their daughter. They're taking care of the grandkids while their daughter goes back to school, okay? Those grandkids don't really care if grandma's showering a minimum of 3 times weekly over the next 90 days, right? It's not as relevant as an objective, okay? You might have objectives around grandma being able to safely retrieve them from the bus stop, or being able to cook macaroni and cheese, or a meal on the stove, and to do that safely. Being able to know emergency procedures and contact 911 if there's ever an emergency. So you see how in that case, the need area around hygiene is much less relevant to the overarching goal of what someone wants to do. So just be thinking about the relevance before we're talking about adding these objectives to the plan. And if you struggle, or the people you supervise on your teams, if you struggle with crafting these short-term SMART objectives, because they're technically, again, very tricky, I just offer a formula to you here on the screen that will help you hit those required elements. So within what amount of time, right, is the person going to have an improvement in which barrier, right? Like which barrier are you working on overcoming, as evidenced by a meaningful change in functioning or behavior that's getting in the way of a person's life goal. So like in this first one down the bottom, this was somebody who the goal was employment oriented. They wanted to keep their job in New York City, and they were struggling with really significant panic attacks. And not surprisingly, sometimes riding New York City public transportation could trigger those. And John had been having difficulty being late for work or missing work because he would sometimes kind of get off the subway stop before he got there. So you see down the bottom there, within 30 days, he's going to have improved management of panic as evidenced by successfully getting to work on time without exiting the train before it stopped, okay? So kind of chunking out these pieces and still tying them back to the clinical presenting issue that's getting in John's way, right? This one is perhaps among one of the most important quality tips you're going to get this afternoon, because it's one of the most common quality errors in treatment plan documentation that, in my opinion, really moves them away from being both person-centered and productive. So sometimes we do a really nice job together with people getting a handle on the long-term goal statement and what's important to them. But then we drop down to the level of the short-term objective. And I see a lot of Janis will attend therapy. Janis will meet with the job coach. Janis will go see the psychiatrist. Janis will meet with the substance use counselor. So all those things are an important part of the plan, but they are not the short-term objectives. Short-term objectives really should not be about service participation. Those things I just mentioned, those are interventions that we're going to build in a bit, okay? When you write the short-term objective, what we need to be asking is, if I'm going to all of those services, what do you think could be concretely different in my life in a short amount of time? So to give you an example, the one on the screen here, Wanda, we'll call her, was someone who had a very serious trauma disorder in terms of emotional dysregulation. had a lot of difficulty with self-injurious behavior, specifically cutting at very high frequency and intensity. Wanda was married, and at a certain point, Wanda's husband kind of got burnt out, and there was some conflict there, and they separated for a bit. Okay. And the team did a nice job of recognizing that Wanda's goal was to reconcile and rebuild the relationship. But when you drop down to the level of short-term objective, right, the short-term objective is not Wanda's going to attend dialectical behavior therapy. That is the intervention. If Wanda goes to dialectical behavior therapy, what do you think is going to be different? That's how you get to the short-term objective. Maybe she's going to use mindfulness techniques to reduce instances of self-injury to no more than 1 per week for 2 consecutive weeks. It all depends on where the person is starting, right? You would negotiate that, right? Maybe Wanda's starting to feel better, and maybe Wanda feels ready to say, you know what, I want to use some different strategies, and I want to have, a whole month here where I'm not feeling like I have to use cutting or self-injurious behaviors to manage some of the distress that I'm in, okay? For those of you this often comes up in the substance use services space, okay? If a person wants to go back to work, substance use has been getting in their way. The objective is not attend the relapse prevention group. I mean, you all probably know that a person can religiously attend all of your groups, go to IOPs. They might even be able to teach your groups if they've been in them more than once. And they could walk out of that group and purchase substances down the street, okay? You have to be asking the question, if the person's responding and our services are effective, what do we hope to see being different? And that would be, a measurable reduction or elimination of the substance use, okay? So this is something I tell people, plan writers, I wrote plans for years that had, Joe will attend the doctor's appointments, Joe will show up at the clubhouse, okay? It's a pretty easy habit to break. And I tell clinicians, when you sit down with somebody and you're writing a plan, almost if you see the words will attend pop up, you want to strike them from your vocabulary, because that's almost always a kind of a clue to you that you're slipping into this kind of quality flaw. The reason I spent a lot of time on this is because people honestly can participate religiously, faithfully in services for years and years and not get better, right? And we need to write the objectives in a way that we kind of are able to reflect on whether or not what we're doing together is effective, so that we can switch up the plan if needed, okay? Very hard to break that habit, right, Cindy? Just not will attend, not participate in, focus on the short-term outcome, what you hope they're going to get out of services, okay? All right, couple of slides quickly on objectives so we can get to our poll. You can scale them up or down depending on what feels manageable for a person. And this should be a dialogue with them, like everything else in the plan. So somebody wants to work, they're so severely depressed they can't get out of bed. Arguably, they're not running out to 3 interviews in the next 30 days, okay? So I'm just kind of trying to give you examples. Maybe you start really small and you're kind of targeting that sleep disturbance and just making sure that, somebody can get out of bed by a certain point in time over the next, couple of weeks, month, whatever it might be. Then maybe they move on, they draft their resume, and then maybe eventually they are having such effective management of the issue that they've actually got that part-time job that is so important to them, okay? In a similar vein, we want to scale up or scale back on short-term objectives so they are responsive to the stage of change that a person is experiencing, okay? I want to be careful. I don't use stage of change theory to slap labels on people. That's not the point. But I do think that understanding where a person is at in the recovery process helps us tailor a plan that's more tailored to them and where they're at. We always say we meet people where we're at, where they're at, it's responsive to them. But the truth is, if somebody comes into services and says to you, I don't got a problem with the booze. I don't have a problem with the pot. Like, I've been doing this for 20 years. I'm just here because my wife sent me here. The judge sent me here. I'm gonna get out of here, do my time, right? Given where that person's at, they're not even recognizing that it is an issue or seeing the consequences of it. You don't want to be right in a short-term objective that's about lifelong abstinence in the next 30 days there, right? You want to be tailoring it to start more modest and be thinking about that cost benefit analysis and saying, maybe in the next 30 days, Joe's just going to come up with, identify 2 negative consequences of continuing to drink, or like 2 potential benefits in his life about what it could look like if he is able to change some of the use patterns. All right, we are going to open a poll here, but this is a very dense section. Did we have any questions, Robert, that you saw come into chat that I need to pause for yet, or do we want to just go ahead and open the poll?
I have not seen any comment in the chat, so I will go ahead and.
Okay, go ahead and open the poll so we can finish on interventions and hopefully save a couple minutes for questions. What's the best objective? Now, remember what Roma's goal is, everyone. She wants to be a better mom for her kids and work on getting custody back. So what would be the best short-term objective that meets the criteria we're talking about? Just going to give it just maybe like 10, 15 seconds, Robert, and then we can close this one. So I'm sure to pace myself.
Sure thing.
Oh, I figured out how to see it in a bar graph. All right, what do we got though, Robert? You want to do a little synthesis for me? That's been helpful.
Sure, yes. Looks like the vast majority said letter B. Within 30 days, Roma will have 3 successful visits with her daughter without outbursts, as evidenced by her self-report and cousin's report. The next closest was letter A. About 10 people said case manager will refer Roma to community parenting group within 1 week. And just a few people answered the other 3 options, respectively.
Okay, all right, good, that's helpful. So, for those of you who went with our gray box, our box B, I would say yes, that is the one that best meets our criteria around a person-centered, smart, short-term objective. You know what the time frame is, you know exactly what she's working on and targeting, which is this sense of feeling out of control and having outbursts at home. And you know how it's going to be measured, that they're going to self-report back that these visits are more successful, okay? So the top one is a little bit tricky, okay? But just keep in mind, a community parenting group could be great for Roma. But again, even a community parenting group, just like psychiatry services, substance use services, that's more of a service or a support or an intervention. It's less of kind of an outcome. The outcome Roma wants, Roma tells you, I want to feel more control at home. I want to have a better relationship with my daughter, okay? And then some of the others, the blue and the green, those slipped into that trap of they're talking about attendance at services or participating in services, right? Rather than like, how do I feel better as a result? And then the golden one in the middle there, the anger management, that's lacking in its technical measurability. So that's why that one wasn't the best. All right, home stretch. So Donald is asking a good question. I see it before I'm on. When you talk about successful visit, so you want to actually work with the person around how would you define and operationalize what that looks like. In this case, Roma really was kind of openly recognizing she was kind of flying off the handle because of a trauma response. And she was having some of these outbursts. So it was focused on kind of having these visits without having those outbursts. An even better measure, if you're talking about successful visits, because again, you want to define it. That's what I think was being pointed out there, is can we identify something positive that they're going to actually be able to successfully do together on a visit? Okay, so you do want to get some kind of measure around there. In this case, Roma really was focused on trying to better understand, again, sort of that loss of control that she was having. Okay, good question. All right, interventions, action steps. Finally, we get to the part of the plan where we're documenting who is doing what exactly to help a person make progress in their recovery. We might be including some of our evidence-based practices. We're still respecting individual choice and preference as much as possible. And we are documenting our interventions in a way that they are further supporting both clarity in the treatment, but also supporting our golden thread of medical necessity. And in terms of doing that, it's really critical to be noting what I say are the kind of key W's. Who's providing the service? What exactly is that service, right? When is it scheduled? Frequency and duration? Is it once a week for 3 months? Is it one time every 3 months? And then why? Just a little bit about the individualized intent and purpose as it relates to that individual and their objective and goals, okay? These don't have to be lengthy description of purpose, but that why statement often gets missed. And when we miss that, we miss an important opportunity to individualize the plan. So I just offer you a couple of examples up here on the screen. So maybe you've got a rehab specialist who's doing a community integration group, 1 time a week for 6 months to help somebody learn skills to access the public transportation system. Maybe they're even doing anxiety reduction and social skills training, out in vivo in the community. Maybe you've got an addictions counselor who's providing motivational enhancement. Who's doing it, what they're doing, the time during weekly home visits over the next 90 days. And what's the purpose? We're trying to encourage Oliver to decrease substance use. Maybe we're, again, kind of mapping out what some of the consequences have been, talking through benefits of reducing use, whatever it might be. Strategies for decreasing use. And then my last point on the intervention section would be this, that interventions tend to be a long list of what all the professionals do. The doctor does this, the substance use counselor does that, the DCF worker does this, the case manager does that. But if we write plans that are all about what all the professionals do, and if we don't make any space for what the person is doing in the service of the plan or their natural supporters, then we miss an important opportunity to build an individual sense of agency, and also to build a circle of support to help kind of hold up a person over time. So I would encourage you to be thinking, in that intervention section, what's something that the person is going to own, an action step that they can own. I give you some examples down here on the left. Elaine may be very depressed and struggling and feeling hopeless about the future. And maybe she's also somebody who loves to use the computer and she loves to read. So maybe you're offering some great clinical health services, but maybe, you're pointing Elaine in the direction of reading these web-based recovery narratives at night, okay? Similarly, on the right-hand side, natural supporters, how might they contribute? Like before we have a social worker, a case manager trying to figure out how to drive or get somebody to Sunday services, do we reach out to somebody, Father Cronin in Hilda's church and see if there's a fellow parishioner that might bring her? We're not on the hook for these actions if they don't occur because we're not providing them. Okay, so that's a concern that comes up a lot. But nonetheless, exploring them and building them into the plan is a really important part of the overall person-centered approach, because it allows a person to tap into their personal and their kind of natural supports in a way that hopefully it reduces their sense of kind of feeling dependent on or surrounded by the kind of professional treatment services. So I'm going to open the last poll here, prompt Robert to do that. And you get an option to pick 2 with this one, I think. Did we set it up that way? I can't remember. Did we catch that?
We did.
Good. Okay. So there's 2 types of interventions here that could be nice addition to Roma's plan. So please go ahead and pick those. About 15 more seconds, and we're just going to share out a little bit. All right, what do we got, Robert?
So it looks like the most, or the answer that received the most was C. Sally Rodriguez, clinician, will provide trauma-informed individual therapy.
Yep.
That was about 41% of respondents. 28% then said within 2 weeks, Roma and her cousin will check into arts-related activities. And then it looks like about 10 people each answered the first 2 questions, and only a couple answered the last.
Good. All right. So let's start with that kind of golden and the blue. So I would say for folks that responded in that way, that those are the best examples. The golden one is a really nice example of a well-documented professional services intervention. And the blue one is a nice example of kind of a self-directed and natural support intervention. You know, who's doing it, what they're doing, when, and why. Okay. The orange one is a little tricky. We got a handful of votes for that one, because in some ways that has, you know, a number of the required elements. It's missing kind of our duration over what period of time, but more importantly, remember what Roma is working on in this part of the plan. Roma's working on kind of feeling more in control during those visits with her daughter, okay? So it's just not quite as relevant. The orange one is not quite as relevant an intervention in this part of the plan. What Roma really needs to achieve this short-term objective around the visits with the daughter is that good trauma-informed therapy in the golden there, okay? You might have a second objective, for example, in the plan where Roma's getting some money management support so she can, you know, better manage her bills and pay her rent on time, okay? All right, I want to leave. I'm going to say one more minute here, and then I'm going to open it up to any questions. There will be a link in the chat box. Thank you, by the way, for participating in all of those polls. I hope you found it practical to think it through and illustrate it with Roma. This is a really nice resource. People have liked this in my travels because it essentially boils down into just a couple-page document, a lot of the quality indicators in the documentation that I just reviewed together on the webinar today, tips for recognizing a good person-centered plan. And then the last resource I'm going to leave you with is a sample Roma plan, okay? We can also drop that link in the chat. You're gonna have it. You don't have to worry about the tiny font here. There's gonna be a link to, like, you know, a full-size document. But what I'm hoping is you have an opportunity to go through the Roma plan is that you can see, you can organize a plan around that goal that is most important to Roma, right? She wants to be a better mom for her kids and work on getting them back. And yet you can still target things like conflicts with the daughter, ongoing concerns about her substance use, Roma even having concerns about the alcohol use, right? Needing to take care of medical issues so she can be healthy enough, when she gets her kids back, being able to more independently manage her money, so that she can run a household someday, okay? You can target those things in the short-term objectives. And then down in the interventions, I've just tried to give you lots of different examples about how those might come together in a creative way that you have both professional and natural support interventions. And I will just leave you with the caveat that there could be many, many ways to write Roma's plan and co-create it with Roma herself, okay? I offered you 4 different interventions in this objectives, and this plan is lengthy, okay? If you're working with Roma, you may pick and prioritize and start working on one of those areas, and then maybe you add the others in the future. I simply had one goal with 4 objectives because I was trying to give you diversity of content, just because I thought that would be helpful. So hopefully you see by concluding there that we can write plans that both honor professional experience and the wisdom of lived experience. And we can do that in a way that we're weaving our golden thread of medical necessity, because I do understand that you continue to have requirements and expectations around compliance with billing and fiscal regulations. So I leave you with this parting thought, and I do have about 4 minutes, it looks like, if there were any questions that came into the chat. Hopefully I tackled some of them along the way.
I have not seen any additional questions come in.
Okay, so I'm seeing that people find the tip sheets helpful. Yes, please do. Feel free, download those. Glad it was helpful. Some individuals may react to Roma new. What about a new future? So that then, I'm glad you picked that up, Nancy. I'll actually tweak that. So by new and improved, we didn't mean new and improved Roma. We meant new and improved plan. That the plan was actually on track and more person-centered. But I like the idea of incorporating the, a new and more hopeful future. Lots of folks seem to think it was helpful and practical. I'm glad to hear that. Robert, you need a minute for closing technical.
Yes, thank you so much for your time. I did see one person in the chat asked for the tip sheet, so I posted those in the chat. So you may have to scroll up. I know there's a lot of people saying thank you to Janis for her time. So, but those are posted most recently. Please hang on for just a moment for some closing business items. I want to thank you, Janis, for your time, dedication to this presentation today. Getting a lot of great feedback in the chat. So thank you so much for sharing your expertise with us.
Of course, my pleasure.
I will say, ladies and gentlemen, I'm posting 3 different links in the chat right now. We have an updated PowerPoint. The PowerPoint shared at the beginning had a few slides removed as to not give the answers away to the exercises, as well as I pasted the updated Roma assessment with a person-centered recovery plan, and I've posted a link to the evaluation. So all of these resources are now posted in the chat. You can also access them at any time via our website at www.fada.org. If you go to the events tab at the top of the screen, click on upcoming training. There is an option on the calendar to view past training. So click on past, then click on the title of today's presentation. You can view all of the files shared today under webinar downloads, including the updated PowerPoint and the updated Roma plan. Please remember, when you access the evaluation, you will be prompted to sign in or register to complete it. You can register as a visitor at no cost if this is your first webinar with us. You may do so by clicking haven't registered yet. Please remember to use the same email address that you used when you registered for today's webinar when you set up your profile in our system. This is the only way for us to connect your attendance and your profile. After you register or sign in, you will be directed onward to the evaluation. You will also get a second opportunity to complete it later today through a follow-up email. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking Edit on the professional information section of your profile. Please note that the evaluation will close at the end of the day on Tuesday, April 2nd. If you have any difficulty accessing your account or completing the survey, please contact our team by filling out a contact form on our website as shown on the screen, or by sending an email to training@floridabha.org before April 2nd, 2024. As a reminder, we do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after the evaluation closes. The recording and materials used in today's presentation will be available on our website within 30 business days. To access the recording and PowerPoint, visit www.faba.org, navigate to the Resource Center, and then click on Training Library as shown on the screen. Thank you everyone for participating in today's webinar. I'd like to thank you again, Janis, for your time and expertise. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Everyone have a great day, have a great weekend, and please hold for the evaluation.